And someone is your Ghana. All right, distinguished ladies and gentlemen, at this point, we are zooming into our panel discussion. And I am honored to invite Dr. Nana Ya Che Frimpong as one of our panel members. Let's welcome her. We'll be joined by Dr. Francis Adai. Doc, thank you. Dr. Linda Decker would also join. Then finally, Dr. James Dua. You have Dr. Dua here? Very good. This session will be moderated by Dr. Nana Kofi Edu Afari. And Doc will surely make the panel members introduce themselves better.
Good afternoon. After that dance, we can't have that response. Good afternoon. Thank you very much for having us. My name is Nana Kofi Edu Afari. I'm the quality manager for Safe Care, which is the quality improvement program under Farm Access. And this afternoon, I'm humbled to have been invited to moderate this session. Casting my eyes around, I can see a lot of new faces and a lot of familiar faces. So I don't know whether it's mixed feelings or mixed emotions. Dr. Chawe, do you have a diagnosis for that feeling? Not yet. So thank you very much. You're most welcome, ladies and gentlemen. Should we mix them up? No, let's mix up. Let's mix up. Let's mix up. Good. So we are actually going to talk about integrating digitization into health systems to achieve UHC in the context of what we've been talking about since morning. Who does not have a mobile phone here? Please, if you don't have a mobile phone, let me see you by hand. Oh, I was going to dash you an iPhone 15. If that's it, then you don't have. That's a very conditional answer. Are you a politician? Yeah. There's been a lot of talk about digitalization, and I was just checking some statistics online. Realized that currently 44, though we are 34, we're around 34 million in population. We have about 44 million mobile phones in the country, which means some people have 2, others have 3. Some buggers have like 5. They hold 3 here. And there's a special way they walk when they're holding 3 and 2 here. You know, their arms are like that of a crab, koto. So there is that talk about digitalization. Some few years ago, maybe 10, 15 years ago, we still used to buy tickets at the train stations, at the bus stations. I remember those times you go to STC, you have to go and book your ticket ahead of time. But now what do we have? You can buy an airplane ticket from the comfort of where you are sitting right now. That's the power of digitalization. And if you care to know, we are under that revolution now, whether we like it or not. It has come to stay. However, statistics also show that health is lagging behind. All other industries, talk about it, media, transportation, Uber. Uber came just quite recently. Oh, Bolt, and now there's Mango, Tango, Yango, Bango, all the angles you can think of. Digitalization has come to stay, but health is lagging. And this afternoon, we are just going to take a quick sweep through that discussion, and I'm sure by the time of we are done with this panel discussion, you would also pick 1 or 2 nuggets to roam around with. This afternoon, I'm having a beautiful and handsome panel members. Let me start from Nana. Dr. Nana Yafripo, Yeah, could you kindly introduce yourself? I've mentioned your name. That's all we know about you. So tell us anything you want us to know about you.
Hello, I'm grateful to be here. Good afternoon, everyone.
Good afternoon.
My name is Dr. Naneachi Frimpong. I'm an internal medicine specialist at 37 Military Hospital, also a senior resident in neurology as well. Um, I don't know what else you want me to
Anything you do for fun?
I like scuba diving for fun.
Ebi Ogana. Scuba diving.
Yes.
Eh. Where do you do that?
Well, I haven't done it in Ghana yet, but I've done it in
Oh.
various areas of the world.
Fantastic. At least you have a life. Doctors don't have a life. All right.
Thank
Let me
you.
have Dr. Adai. Dr. Francis Adai.
Thank you. Good afternoon, everyone, and then good afternoon to my co-panelists.
Services like Focus, if they are willing to make sense of their HR needs, to fill in HR gaps. It's a service that we're hoping to extend into the public service as well. So a little bit about what I do.
Fantastic. Dr. Dia.
I'm James Dia. I'm a public health physician. I work with CHAG as the Deputy Executive Director. I'm in charge of health services delivery. And we fit into the keynote speakers, the last area. We work in rural areas. I've also been championing NCD care within the CHAG network. And I think without doubt, we have the largest single data on non-communicable diseases through digitalization.
Sure.
And I'm happy to be on the panel to share some of our experiences today.
Fantastic. Please let's give him a round of applause. So during the break, we're having discussion, chit-chats around, and I did mention to Prof. Okosio say that at some point in my career, I had to sit at the consulting room and see 224 patients. Hello? Hello? A day. Clinic started at 6 a.m. We finished 7 p.m. But even if you do the math, the number of minutes divided, so you can imagine, Jekwajedru, you can imagine the quality of time that was spent. Now, moving forward, maybe let me take it from Dr. Decker first. There's a lot of prevalence of NCDs, and I think this morning we've talked a lot about that. My brother Christopher shared his side of the story. It's been a lot of talk. I don't know whether it's a curse to be quote-unquote poor, because then every bad thing or every disease is associated with sub-Saharan Africa. In your opinion, what do you think is the critical impact that remote care in the form of digitalization and its accompanying technologies can help in improving the management of these diseases?
Thank you, Doc. I like the way you began. And in my time in public service, I never saw that many patients. So it means that over the years, things have really changed, where the burden of disease has increased. Now, what that tells us is that it's not physically feasible to provide quality with inpatient, in-person interactions, which is traditionally the way we provide service. So if somebody comes to the clinic, they queue. And the queuing can be quite profound, where you have hours of waiting. And contrary to what we think, we have even ordinary Ghanaians. The market woman has to get up at 2 a.m. to be on a, in a taxi by 3 to get to the market to be able to sell her wares. So if this person has an issue and has to present at a facility, or even to pick up her medications, it's asking her to be less productive. That day, her family will not eat. And so one of the things we need to do is to shift the way we think around service provision. What this means is let's look at a way in which, and that is remote care, let's look at a way in which, does the patient really have to come to you if the blood pressure is controlled? Does the patient really have to come to you if they've run out of medication? And in our screening services, I know that a lot of public sector and private sector hospitals have insurance. How do we reduce the cost of care for medical screening? So I think we need to do a shift in the way we think around service provision. What sort of, you mentioned mobile phones. Everybody has a mobile phone. On that phone, we make calls, we send text messages, we carry our data, we carry our mobile money, we do mobile banking. So is it possible that there can be a solution that uses a tool that is widely available to most people? And mobile phone penetration goes as far as the remotest village, where now you can send money to either a family member or money to a parent all the way in the village. So if we look at these tools, the ground has already been laid for us. Is it possible to use this tool to be a platform on which we can provide service? And I think that in those terms, digitization is a solution where we can provide service to most people at a reduced cost. I hope I've answered part of your question anyway.
This is adult education, right? Fantastic. So, Francis, to you, you have seen thousands of patients living with diabetes, and please let me use this platform to encourage us not to call people by the conditions they have. Say the diabetic man. You say the patient living with, because after the disease, the person has an integrity. The person has a life. It's called the reductionist principle. If you call somebody by their disease, the sickle cell patient, the hypertensive boy, you are labeling them and reducing their dignity to the condition. Please, I hope we are good. Fantastic. You've seen lots of patients living with hypertension and diabetes. And most recently, I'm sure you've been exposed to one example of such technologies like the NCD care, which PharmAccess piloted in some key hospitals in Accra. And now we are scaling up to other regions as well. Can you give any tangible example of where this technology actually helped or assisted the patient to achieve their targets?
Right, thank you. And always grateful to PharmAccess for partnering. So before I moved to join Focus Orthopedic, I worked with University of Ghana Medical Center 2.5 years. And post-COVID, we used the same app virtually during COVID to monitor our patients remotely. So post-COVID, we asked ourselves, can we use the same app in a modified way to follow up our patients with NCDs, particularly hypertension and then diabetes. And we rolled it out. And I must say that when you look at chronic care, I mean, another name for NCD is chronic disease anyway. Chronic care has moved away from provider care driven to self-care. And if you look at the concept of diabetes management and then education in terms of self-care, the 7 pillars, the app gives us the opportunity to have all the 7 pillars. So you talk about coping mechanisms. So you get real-time interaction with the patient. And she mentioned about the fact that it gives us the opportunity to reduce the numbers because you can actually interact with a patient on daily basis. We give them the opportunity to feed us with their information twice weekly. Those that are poorly controlled, sometimes we do it 3 times a day. And so for most of the patients I counseled and then rolled onto the app, I was able to follow them up real time. So I'll go onto the app, and by the time I do that, they've logged on their BPs, they've logged on their sugars, I'm able to follow up with their BMI. There's a lifestyle aspect of it, what they eat, the activity level, and all that. So with time, you are able to tell whether your client is doing well or not, vis-a-vis the patient having to travel. And I had one professor who was referred to me. She lived all the way in Kaswa, and she comes to see me at UGMC. And
Kaswa.
yes. And when I asked her to roll on to, she was so excited. So one, her traveling time, expenditure through transportation were all reduced. And today she's very, very happy. In fact, she is one of the advocates when it comes to the NCD Care app. I can't mention her name here. You know. So it's been tested and tried, and I think that it is the way to go. So the issue about empowering, which is education, helping our patients to manage themselves better. We can do it efficiently remotely, and I think I have tested and tried it. So that is a practical example I want to share.
Fantastic. So there's the story of an very old doctor, almost hitting 90 years, who got hold of an iPhone. I mean, you know, those days we used to use the Atepa. You know Atepa phone? The one you used to turn the number like this. How many of us met that phone? Oh, very few. Uh-huh. So, I mean, he's used to that kind of phone, and they bring him a mobile phone. So he was calling his son to discuss an issue with him. He had actually sent some money, and so he calls. Hello, Kwame. How are you? I've sent an amount of 2,000 Ghana cedis. So share it as follows. Kweku, 500. Do you get a gesture? The phone was in his armpit. Kweku, 500. After he finished everything, he goes back to the phone. Did you hear what I said, sir? You didn't hear me. I said, hold on. Kweku, you know how people are very used to doing gestures on the phone. And when there was the advent of earphones and earbuds, now iPods and all that, if you're not careful, you think somebody needs urgent psychiatric attention. Because the gestures that go along with that. Now, let me come to you. So, you coming from the provider side, I'm sure at the clinic side and all that, are you in the position to actually collaborate with others to integrate them? Because there's a lot of resistance sometimes where we come from. We are all used to the old ways of doing things, you know. Not to belabor what our chair said about neat fufu, but I know the chair, if you give him neat fufu, he will be able to tell you that this is not Tim Tim, this is neat fufu. From your perspective, how do you think we can actually integrate this into our systems, collaborating with other partners to achieve this?
Well, thank you very much for the question. So healthcare providers are uniquely positioned to be the bridge between government, officials, policymakers, NGOs, and tech firms, because we interact with the patients one-on-one. So we're able to give unique insight to what the patients need, how they need to utilize their phones to access healthcare, how they're using their phones, whether they have digital literacy, and be able to also give that same information back to the stakeholders as well. Where we're also uniquely positioned, we're able to give insight on training programs. And this goes both ways. Again, to educate the patients one-on-one, but to also educate the providers as well. And when we say providers, we're not just talking about doctors, nurses, dietitians, and all of that. Because in as much as we all have digital phones, we know the phones are being upgraded all the time. And we also have different types of platforms, okay? So we being as a bridge, we're able to educate and give advice on training programs that go both ways. We also actively test different digital tools which are available, okay? So just because an app works in, I don't know, a certain community, it might not work, the same app might not work in the same community the exact same way, Okay. And also, we also have to keep in mind language differences because not everybody understands English. Okay. We are uniquely placed so that we can ask our patients, oh, okay, so now we're using this app and it's in Ewe. Did you understand everything that's there? Our educational themes that we send in, do you understand them? Yeah. Are you getting feedback appropriately? So I think we serve as a good bridge. And as well, we have the unique platform of understanding the data that we get from these digital platforms. We're able to interpret our data in real time, as my colleague said, and we're able to identify trends which can influence decision making. We're also able to optimize treatment plans based on real time data. So I think healthcare providers are uniquely placed in that aspect.
Fantastic. Dr. Dia, I know you do not represent government. I know. Please don't hang him. He doesn't represent government. But from where you sit, I'm sure you've been privy to a lot of deliberations at government level, very senior, very high level, with all the work you've done in NCD care. How strategic now would you deem the partnership to digitalization in this fight against NCDs?
Thank you. I think government cannot do it alone. That's a fact that we are aware of.
Now he represents government.
I don't represent government, but I want to make a point that government cannot do it alone. We have a lot of priorities for government. But even let me narrow it to the health workers, as everybody has said. So recently we are doing a work that I had a very shocking statistics. And that data saying that of all the people with NCDs that are within our network, it's only 48% of them, those that are actively seeking care, that are educated on their condition.
48.
Only 48%. If you translate it, statistics will say 5 out of 10.
Yeah.
If you don't want to be a statistician, let's put it at 4 out of 10. Now, this compares with the data that says less than 35% of people who know their condition as either hypertensive or diabetic who achieve good control. Less than. So when I got this, much as I was surprised, it also showed that, well, that is why we are getting the trend that people who are actively seeking care, they are not getting control. Now, for the past 3 years, we've done a lot of work. Last year alone, we were able to bring into care about 76,000 people using digitalization, primary healthcare approach with Metronics, educating people in the community, screening them and all. And the question is, if, let's say, a private or non-governmental organization like CHAG is not there, aware that government doesn't have presence in everywhere, these 76,000 people probably will have died, or some of them will have had complications that they are not, they were not aware of. So the need for stakeholder involvement, private sector, is more paramount. We are working with pharmacists now, and let me go back to this statistic. So when we got this data and were surprised, we asked the health workers, so how come people will come to you with hypertension, diabetes, and they are not getting education? This is not good practice. It doesn't speak of quality. But I think the answer is what you said in your intro. You have people working in the rural areas. You have 100 people, 80 people behind your consulting room. And I've had that experience when I worked in Kumbungu for 10 years. Even to get out to go and eat is a problem.
Yeah.
And so the practitioners are telling us, we do not have the luxury of time. It's not that we don't want to educate people, but we don't have the luxury of time. I can't even get 5 minutes on a single patient. Otherwise, the unintended consequences of that action, much as you want us to educate them, is that you have also prolonged patient wait time. And then the patient don't come again next time because they say, we go to the hospital. We spend 8 hours.
Yeah.
So why should we go? Then they resort to all the places that we can't think of. So it's clear, even the health sector, the health professional, health system cannot address it. This is why we are working with pharmacists. They are experts in areas that can be leveraged on, and now we are talking about leveraging on the power of technology to reach out to everybody. You spoke about mobile phone penetration, which is about 140%. If 44.9 million people are having mobile phones now, and we are using it for WhatsApp messages and all that.
TikTok.
Yes, we can use that medium to deliver, which is what we are doing.
Yeah.
So for the 76,000 people plus, we can be able to reach all of them through technology. We are working with National Health Insurance Authority, moving away from volume payment. So 1,000 people have gone to facility A. They submit claims, they are paid 500,000. Another 1,000 set of people have gone to facility B. 90% of the people have gotten better, but they are receiving the same level of care. So the collaboration between government entity, National Health Insurance, and pharmacists is working at shaping the way of care. So if 1,000 people go to facility A and their outcomes are better than facility B, then facility A should be paid higher tariff than facility B.
So now it's more like value for
money. Okay. Insurance alone cannot do it. And that's why private people can come in. CHAG, as a health service provider in rural areas, we cannot reach out to everybody. Even if you give us 100 days, every health worker move into the community, we can't do it. But an innovative organization like pharmacists, or let's say Medtronics, can give us power and technology that will allow us to reach. So the answer is yes, we need to go beyond government. Government should be the controller, coordinate affairs, bring in experts. Within the church health service, we have a policy, subsidiarity. If one organization knows how to do something better, don't take it and do it. Let them do it. So the power of technology, people who are specialized, let them deliver the messaging. It's not surprising that the air hostess, they write messages for them and they read verbatim. I'm sure you are, when we are talking about education, you are thinking about how can non-health professionals do it better. We can write the messages for the media. Let them use all the enthusiasm and the energy to deliver that. Let's deliver concept of mobile phones and deliver it to the point of use. I think I'll end here.
Let me come to you, Francis. So what do you think are some of the key challenges and barriers? I mean, you can envision a very good, story or a very good intervention. But in terms of challenges, barriers, in your opinion, yeah?
Thank you. Before I come to the challenges and barriers, I'm happy we have quite a number of healthcare providers here because we play some role. And just to add to Dr. Due's statistics, the issue about NCDs and its consequences is dire. And I had the opportunity of joining the grand rounds of UGMC in July. And I was amazed to find out that between the ages of 36 to 45 years, within the neuro center, they were dying from hemorrhagic strokes.
36.
Of all their hemorrhagic strokes, UGMC has a policy that once it's a hemorrhagic CVA, depending on certain parameters like GCS and other things, they end up with the neurosurgeons for interventions, early interventions. Because the idea is if you're able to intervene within 6 hours, you can save a life.
Yeah.
So they're doing a 3-year prospective study, but they had a preliminary assessment of what they've done in just January to May. And of the mortalities, 38% were between the ages of 36 to 45 years. And that was stunning. And it ties into the presentation made by our keynote speaker. In Focus, we did a 5-year retrospective study of our auto cases, and we had about 329 within a 3.5-year period. Out of the patients we operated on, 83% had one form of NCD or the other. 67% had essential hypertension, and 22.23% had diabetes, type 2 diabetes. And 28% had both diabetes and hypertension. And it's our policy that if it's not an emergency, we defer surgery and optimize you very well before we operate on you.
Yeah.
So the issue about NCD is bigger than we think or see.
Yeah.
And so when it comes to the use of modern technology, practically, I saw it when I was at the UGMC, and I'll start with the healthcare providers. So I have acronymed it the AIL syndrome, where you have AIL, okay? And we have this tendency of not accepting change. There's this tendency of we not accepting something new. So I want to start with the provider side. So the AIL syndrome, you realize that the A, where the healthcare provider thinks is an added responsibility. And the I say inertia, the unwillingness to do or to change. And the L, I say lack of interest. The person is just an onlooker. He or she is not even interested.
I thought the L was laziness.
You know, they are not just interested. And I think if we should hand over the mic, we have practical examples where you meet as a team that, hey, this is the way to go. And you have colleagues not interested at all. And so these are some of the challenges I have personally identified when it comes to the provider side. Now, the challenges with the clients and the patient. I'll start with, I think Nanaya, in a way, introduced it. There's an issue of literacy, education, because it's an app and it's in English. I know providers have plans of translating some in the future, but for now, most of the apps around are in English. And if the person is not well educated, it becomes an issue. Okay. So literacy is an issue. Now, mobile devices. We have patients who still use phones that are not up there. So they can't even download, sorry to use the word YAM, they can't download an app onto the phone. Yeah. And we had those practical challenges where patients have to go and buy a compatible phone, okay? The issue of cost also comes in because they need data. They need data to download the app. They need data to put in their readings for follow-up and all that. So cost, education, as in literacy, having a compatible mobile phone. These are some of the, and of course, you have patients who are actually not interested in the whole thing, yeah.
But Nana, let me come to you. So in terms of data, you spoke about data, the use of data. Now we are drifting away from just mere analysis by drawing tables to data insights. What's your take on that?
Well, I understand that, again, it's a partnership, okay? Although we are collaborating and we're trying to integrate our data into insurance and universal health care and all that, we have to understand, again, Frank touched on that point. We need to talk about cost effectiveness, okay? The point is, digitizing our healthcare is cost effective, okay? It improves healthcare costs across the board. It reduces hospital stays, it reduces the cost of medications, it reduces the cost of rehab, it reduces the cost of transportation, Okay, so integration of digital health tools, absolutely, absolutely commendable. We also have to understand that integrating data and integrating these health tools actually gives us a basis for evidence-based decision making. We get a lot of information when patients are inputting their data into the health facility, the health tools, and we're able to make decisions as healthcare providers. Also, as a population, we're able to identify trends. We're able to also identify high-risk populations that we might not already be privy to if we were not doing that. But again, with this data, there are very unique challenges. Privacy is a unique challenge. And as we want to be able to have different healthcare networks accessing the same data, we also have to ensure that this data is private. Okay, someone can easily steal someone's phone and get all the information about themselves, and that we need to be able to work with healthcare technical firms so that we can ensure that kind of privacy. And again, we need to think about different platforms and the same language for different platforms. So one hospital might want to talk to another hospital in terms of transferring patients, but their operating systems might be totally different. Yeah. Okay, and we also need to be able, again, with privacy, maybe not everyone should have full access to every single patient's data. Maybe nurses might have some kind of limited access, a doctor might have limited access, a dietitian might have limited access. So we need to think about that as well. We've already touched on literacy on both ends, in terms of the patient and in terms of the doctors. And also, we need to keep in mind different platforms for different phones. Sure. I know sometimes when an iPhone is talking to an Android phone, sometimes some things may be lost. So we need to talk about that and be able to find ways to integrate both of that together. And we also need to find a standard when we do reach the time where different platforms are able to talk to each other. So if we can have that standard, that way I'll be able to refer a patient using the same type of form, not different facilities using different types of forms. So this is the way we can use our data and how it's integrated into the patient care that we need.
Maybe the last one from Dr. Decker. How do you envision digitalization in this country? Maybe in a minute? Is there hope?
It's our future. It's our future because it's going to reduce the cost of care. And we're talking about it. When I say it's our future, we are actually using these apps now. We know that there are challenges with language, etc., costs, devices. But there are a select group of people, and these are not the elite, but just the ordinary person who choose to use digital platforms. So we should look at it as a viable alternative or a viable adjunct to what we're doing. I'll give an example where I had to go to Kolebu to pay a bill, and I walked into the gynae outpatients, and just miles and miles of people sitting and doing what? You know, people have things to do, and this is where digital platforms come in, where if it's information about nutrition, if it's information about, it will add value, reduce the costs of care, improve accessibility, because these queues limit access to care. Someone just won't show up and will come and have a baby with all the attendant risks. So it is the future, and we must open up and look at ways in which, if there is a section of your staff who are not, likely to use it, well, go look for the others who will use it, because it's quite user-friendly, so that patients will benefit.
Fantastic. Ladies and gentlemen, thank you so much. We live in a country where everything is queue. You queue to be born, or you queue to be born, You queue to receive vaccination or immunization. You queue to be weighed. You queue to go to school. You queue to pass exams. And you queue to die. And even your dead body cry, you queue to be buried. But the power of digitalization has come to stay. And I think it's about time that the health industry, specifically in the care of our patients and our colleagues and our friends and our families living with non-communicable diseases, is championed. The time is now. Thank you very much to my panelists. It's been fantastic hosting this session. And I hand over to our Honorable MC to take over. We should stay?
Yes. Just within 2 minutes, we can only do 4 questions or comments. Very brief, very concise. 4. Straight to the point. 1, 2.
Okay, thank you very much. That's a very good discussion. I would like to go straight to the point. We are here today talking about digitization of our health system. I believe in this very room, you might have heard about telemedicine in Ghana. Far away, 2011, the Novartis Foundation partnered as Ghana to pilot telemedicine in Ghana, in Amansi West, in Ashanti region, in some districts, 2011. And the systems are there. What is preventing us leveraging that to cover all facilities in Ghana? We are here talking about, I think, Ghana, we want to be bringing new things, different things. This telemedicine has everything to be able to move forward this digitization of our health system. I sometimes begin to think maybe the doctors, you really appreciate seeing patients, one-on-one. I think that is what you really like. Even though you are saying in a day you are talking over 270 patients. I witnessed this when you do monitoring at in the northern region. From early morning 6, the doctor could not even have the time to take even his breakfast. His fridge is there, how to take even drink to take, you could not have the time. This system is there, and we don't want to leverage on that. What is the problem with Ghana? I think what we are saying, it is already there. If you really want to do it, we'll go ahead and you start, and that will be the end. And then we'll continue to build upon it, just like other countries are doing. Thank you very much.
Thank you. Okay.
Right, thank you very much. It's interesting this subject matter is being discussed today. And the question I have is this our solution or is just part of the solution? Most importantly, as we look at primary health care, it's important that we don't sway from the fact that people must have access to health care where they are. It's very, very important. Because I'm looking at this example of a patient who was consulted online, using a digital mean, by telephone. Oh, this patient is like this. Oh, doctor say, call me anytime there are issues. You were calling the person. The person had both diabetes and hypertension. And they were calling. The medication was having issues. I personally went to see the patient. I said, look, this issue, the doctor must see the person. When the relative calls, oh, you are even making the woman panic. But that was the issue. I saw that something was really wrong. But every time consultation on phone is good. But does it eliminate the humanness of health care delivery? Is one aspect we should also think about as we promote some of these things. And of course, the barriers, we've said a lot of them, which had to do, most importantly, if you look at our coverage in terms of network, it's an issue. Cost of communication is very, very high now. Can we ensure that we improve our primary health care? Most importantly, promotive. Because I was just having a discussion. Yes, a doctor can do the health education, but the education doctors do is more of giving people informed decisions about their choices. And that is at the latter end of issues, when people have had issues. But where majority are riding in space, where we don't have good policies that restrain certain things from happening even in the first place. Importantly, controlling our food environment. Now we are talking about galamsey. We are having issues of it in our foods we eat. That is leading to some of these things. And the cost of healthcare, as it relates to the problems that we have, are costs that actually depletes a whole family's income. The moment you get one of these NCDs we are talking about. So for me, digitization is good, but we should know whether should that be a replacer, or should that just be a complementary something? That's my question. Thank you.
I'll do two ladies. My mother is a woman, my wife is a woman.
Okay, thank you so much, panelists. I also have concern, I think he also raised some of them, with regards to I'm in the mental health space. And actually, I don't think, like he said, telemedicine should come and then replace totally the care that we give to patients. Because for some aspects, like we do, your mental state examination, some of the things you need to be in contact with the patient. And I also believe that in some instances, you also have patients who may be aggressive, or patients who have emergencies, which you can't do over these phones, okay? And then there's also that bit of privacy, data security, and that's a very big issue now. And I recently had an example of a patient who came in, was seen on the system. Eventually, the patient comes in every afternoon saying that his data, whatever information that we have, should be taken off the system because they are not comfortable with data privacy. And that's another big issue. And then also, technological divide. We know that basically, in some places, they don't have access to internet connection. So definitely, I know we'll get there. But for now, I don't think it should come and then totally replace what we are doing. But it should be an add-on, especially with the things that our panelists highlighted as to time. I mean, seeing patients in the clinic, taking care of a lot of patients in terms of the time that's waiting time. And sometimes it's a big issue for some of our clients. So let's look at if it should be more of a hybrid because of the other negatives that it comes up with. But I'm sure that eventually we'll get there. Thank you.
The last one for now.
Yeah, so I am into weight loss and I'm a nutritionist and I support what previous speakers have said. So I see it as a laudable idea, a very good one for digitalization. I want to give a specific example that it was during COVID that I realized that I could use WhatsApp to do my weight loss program, and in fact, more people enrolled with the group weight loss program. But I also agree with them that differentiated services are important because we should know who qualifies for this kind of remote service and then who needs to do a one-on-one. So a guideline on differentiated service in this regard would be helpful. Thank you.
Till I have the indulgence of the chair, we said 4, we'll stick to 4. So over to you. There's a mic there.
Yeah. Can I respond? Yeah. Just to give clarity, and I only know what goes on in my center. In my center, if you come in and we're talking about NCDs, your blood pressure is raised. You can go home on a 24-hour halter that will cost you anywhere between 600 to 800 cedis. Or we can sign you up for NCD care, which will cost you a fraction of that. So this is what we are talking about. We're talking about people who would agree to every part of the process. Yes, I have an Android phone. Yes, I can. And the app is downloaded in the office. And there's a trial run done. So in no way are we saying that a first consultation or assessment should be done remotely. However, digitalization has its place, because then that patient doesn't have to come from Kaswa to come and have their blood pressure checked. Or like I had a discussion recently with a branch manager of a bank. She has one of her staff who will be late every day, and it's really, really late because they have to check their blood pressure. So these are the instances where there's a useful place for digitalization.
So Francis, just before you come in, so typically, beautiful submissions from the House. We are looking at a patient who spends about 2 hours in traffic to get to a health facility, probably spends about 30 minutes to get his folder retrieved, if it's not an e-folder, spends another 30 minutes waiting to see the doctor for only 2 or 3 minutes, sees the doctor for only 2 or 3 minutes, only to be told BBI and normal, and then to travel another 2 hours back home. So that is where, my sister, the differentiation, hello? That's where the differentiation comes in. So you select based on the needs. That's what we call patient-centered care. You do not take the patient out of context. You put them in context. A person has lived with a condition for 10 years. All the 10 years I've had, I had a patient when I was in clinic about 2 years ago. I had a patient who is actually an auditor, who has actually checked his BP for 6 years and has drawn Excel sheet. Hello? That man is a serious patient. Excel sheet with the graphs, and he's telling you that his BP has been stable. And this is a man who can actually teach another patient how to even check that. You know how you even tie the cuff influences your results. Okay, so there is, as complementary, Prof, like you rightly said, you do not just come and replace the, of course, we are all clinicians in a way. We can't do that. Francis.
Thank you. Excellent questions and contributions, but I just want to take our minds back. What has been shown in chronic care, what has been proven by evidence, is self-care, education, and management. And the app that I'm familiar with, that is the NCD care. So let me take this out of the 7 key components when it comes to chronic care in the area of self-care, education, and management. The first one I'll make mention of is monitoring. So how do you ensure effective and efficient monitoring? So you have an app that remotely you can monitor an uncontrolled patient. If I have patient selection, like has been mentioned, is so key. If I have a patient who is well controlled, I don't have any basis maybe for recommending, unless maybe the person want to be on it. But I want to use the app to remotely monitor my patient in real time. So the issue is monitoring. The second thing is that when the patient is able to monitor himself or herself, he or she is able to solve problems. And what is the problem? The problem is that you've already taught the patient that, oh, your 2 hours postprandial should not be more than 8 millimoles. And the patient knows that, oh, when I ate 4 slices of yam, my sugar shot to 15. Next time, the patient will try and eat 2. So the patient is solving a problem even before coming to meet you. The last thing I'll talk about is reduce risks or complications. So the patient knows that, oh, when I did my foot care, I saw a blister. And then through your interaction, the patient tells you, have a blister. Quickly you tell the patient, please report to the nearest health facility, because you may have given the patient a 1 month, 2 or 3 months appointment, and the patient is at home. But because of that real-time engagement, you prevent a complication. That is the whole concept. It is not to replace what we are doing, but it's an added on. And the whole idea is that any patient who lives with a chronic education, who is well educated, understands the condition, and is able to manage himself or herself, they live longer and they live better. That has been proven all over the world. And that is what we are ceasing to talk about. So it's not a replacement. Thank you.
On privacy, I think there are enough regulation on this digital space. The Data Protection Act makes provision for how data should be collected, stored, processed, and all that. There's also Data Transmission Act 208, 208, Act 772, which also has a lot in terms of how data should be shared and all. The problem is that, and even Cybersecurity Act, the problem is that we have not disseminated this enough. And once we are thinking and going into this space, what we need to do is to bring all these acts together and make sure that facilities are conversant with them to avoid breaches.
Yes, and thank you again. I just wanted to emphasize again that, again, digitization and telemedicine cannot replace hands-on care. There is absolutely no replacement for hands-on care. And like Frank also said, it really depends on the literacy level of the patient and or the caregiver. Because if someone has a bad infection and they've had a stroke in the past, if you cannot recognize that this person is even sick, a lot of times we have patients coming in with their caregivers saying that, oh, the patient is not eating well. Meanwhile, they have a really bad infection secondary to a bed sore. So it really depends on the literacy levels of the caretakers.